Great. So first and foremost, I'd like to welcome everybody to the quarterly seminar for the Penn State Clinical Translational Science Institute Affiliates program this morning. Before we dive into our presentations from our panelists, which are intended to solicit research collaboration from other affiliates. So as they're presenting, please keep in mind ways and mechanisms that you might be able to assist or participate in the research that's being presented if it interests you. We have a brief presentation from our staff faculty lead, which is Nicole Tarr, on some functional aspects of our SharePoint page. So once again, thank you everybody for joining us this morning, and I'll let Nicole take it away for a presentation of some new functional aspects of our program.
Thanks so much, Wilson. All right, welcome everybody. I am going to just briefly show you our SharePoint page and our Teams channel. Everybody should have access to these. If you don't, please email me and let me know, but you should have received an email, an automated email from the system once I gave you access. And within those emails is where you'll find the links to be able to access the SharePoint page and the Teams channel. So I am just going to briefly show you the SharePoint page if you haven't got a chance to take a look at it yet. Wilson, are you able to see the SharePoint page? Is that what's sharing?
I am, yes.
Okay, great. Okay, so this is our SharePoint page. Like I said, you have the link in your email. Once you access this page, this is a private channel, so it is for affiliates only. And so you'll find information here. There's lots of helpful information. We have just starting from the top, you can click this link to collaborate with other affiliates, which I'll show you when we get to the Teams channel. But everything on this SharePoint page is linked to the Teams channel. So if you click it within SharePoint, it'll take you to Teams. So like I said, you can collaborate here. If you want to share the application with anyone, here is the link for that. And once you click it, it'll open into a new tab for you, and you can just copy and paste that link to somebody if you know somebody that would be interested in joining the program. This is a new function we've added here. It's a very brief survey. We'd love to hear your feedback. This is really helpful for program development for us. So we want to make sure that we're hearing everyone's voice. If you have any suggestions, complaints, compliments, anything you'd like to share with us, we'd love to hear it all. So if you click this link, it will take you to this very short REDCap survey. You can do it anonymously, or you can share your name and email, whichever you prefer. Okay, and then we have several links to important documents that you may find useful. So we have different program documents. We have our webinars. They'll all be recorded so that you can view them at later time points. We have our CTSI newsletter that you can sign up for, our CTSI YouTube channel, our CTSI research request form, and a helpful video that explains translational research versus translational science. So these are all links that you can follow. And again, if you click them, it'll take you to an external page. And then key contacts, this is both Wilson and my contact information. And then there's a section here for upcoming events. So you could always check this to see what events we are promoting. They should always be here on our SharePoint page. And then your new affiliate onboarding video, you can access that here. And then if you click on documents at the top, this is where you can access the folders that are within Teams. So I'll stop sharing this and I will go briefly to our Teams channel to show you that. And then we will hand it over to our presenters. Okay, so here is my Teams application. If you click on the Penn State CTSI affiliates SharePoint page, it has this picture of the Pennsylvania map with all of the campuses highlighted on it. So everybody should have this in their Teams channel. Again, if you're not able to access it, just email me. The default is that we use your Penn State University email address, so the @psu.edu. If you would like to use your Penn State Health email address, please let me know and we can go ahead and add you as a guest. But if you use your Penn State University account, it'll show as a member for you. So once you're in there, Can everyone see once I clicked into the affiliates folder? Yes, okay. So once you're in here, there's 3 folders right now. So we have our general folder, where we just have, it's like our white paper for the program. There's not a lot in here right now, but as we get more documents and program materials, we'll be adding them here. We have this collaboration tab, which is what I really wanted to highlight. This is where you can chat with other affiliates. So if you're looking for collaborators, if you're looking for ideas, if you're just looking to chat and bounce ideas off people, this would be a great place to do that. And then there are files linked within here. So this is our directory. This is everybody's name and email address that's in the affiliate program. So you have everyone's contact information if you'd like to reach out. And then finally, our seminar series, like I mentioned in the beginning of this call, they'll all be recorded, and so that you can view them here for future reference, or if you're not ever able to make a live session. So I think that covers it. I'll go ahead and stop sharing. If you have any questions about this or you have trouble accessing it, like I said, please let me know and we'll make sure we get you the right access. I think that's all I have.
Wonderful. Thank you, Nicole. So without further ado, we'll dive into our presentations of affiliate research this morning. Nicole, did we determine who was going to go first?
Yeah, so we can just follow the order that we have on the agenda, the flyer that went out. So we can start with Stephanie, and then we'll move on to Melanie, and then Nima.
So first, I'd like to present Dr. Stephanie Winklejohn Black, an affiliate member from our Harrisburg campus here at Penn State. Stephanie, feel free to begin sharing and take us away with your research.
All right, good morning. Thank you. Let me go ahead and share my screen. Can you all see this?
Yes.
Okay. All right. I hope everyone had a nice weekend. Happy Monday. I had noted in the description for mine that I am open and happy to chat about potential collaboration. So just keep that in mind. And with that said, I opted to sort of provide broad strokes overviews of some of the projects I've either recently completed or are ongoing. So you can see my typical approach to things as opposed to giving you a deep dive on any particular project. So with that in mind, one thing I've noticed with translational science research is that a lot of it understandably focuses on patient, client, public outcomes, which makes a tremendous amount of sense. And so one thing I think about a lot as a CTSI affiliate, especially since I know some of you, is how does my research agenda fit in and potentially help with those things? And I think you have to slide back a little bit on this arrow here. So a lot of my work looks at provider well-being, and historically that's included psychotherapists, folks in training or in graduate school, nurses, and physicians, as well as provider competencies. And specifically the competencies I'm most interested in surround multiculturalism and diversity, equity, and inclusion work. And here are some of the key ideas that drive a lot of this research for me. So first, there's a mountain of evidence to support the idea that provider well-being and competencies directly impact patient or client care and outcomes. One of the leading catalysts there specifically is cultural competencies. I tend to use more of a cultural humility framework, which focuses more on a provider's just general stance and way of being with a given patient group or individual, as opposed to sort of a checklist of competencies. Now, certainly both are important, but I'll talk a little bit about why I take a humility approach here in a minute. The other assumption or key idea in a lot of this research is that provider well-being and provider competencies do impact one another. And so you've got a bit of a chicken and egg concept here. And one example of that would be the experience of burnout. So I am sure, and it's timed well in the semester, all of us are familiar with the concept of burnout or have experienced it ourselves. And one of the key components of burnout is actually feelings of dehumanization toward others or cynicism. And so you think about providers being overworked. We have a shortage, certainly in Pennsylvania. They're going to be a little more prone to burnout. And if you've got those rising levels of cynicism or dehumanization, which again, contextually is very understandable, it's going to be very, very hard to continue to embody principles of cultural humility or cultural competency. And that in turn is going to make it harder to maintain effective relationships with patients or clients. So think about kind of the spillover effects of each one of these things. It will eventually impact patient outcomes. Given that burnout and shortage of providers, again, we want to be really sensitive to their time. And so one thing I'm really interested in are interventions to enhance provider performance. And they need to be quick, they need to be bite-sized, they need to be scalable, and they need to be accessible. So given some of that, here are some ways I would be more than happy to chat with folks offline later this week or next week or sometime in the future. I can see including someone with more of a training paradigm or cultural framework on as a content expert. I've done some work recently on scalable and accessible training for providers, mostly using online platforms that have shown some shifts, even in 8-week quick programs would require 10 minutes a week, some shifts in competencies related to culture. Other interesting things here would be developing training and supervision processes. Nicole, did you have a?
Yes, I'm so
Yes,
sorry.
I'm so sorry.
I just wanted to, I'm sorry if you're hearing feedback. I just wanted to let you know we have 1 minute left in the presentation and then we'll have 5 minutes for Q&A.
Absolutely. So those are some of the ways that I'd be open for collaboration. And then to give you the deep dive, quick 1 minute overview here, this is what my team and I have done recently using some external funding. So we did develop a scalable training program here using a deliberate practice paradigm, which means you give feedback every week. We were able to deliver that to 60 people with just 2 people working part-time as trainers. It had scalable, flexible implementation, and ongoing analyses do indicate that the training condition participants did see a shift in their capacity for cultural comfort relative to the control condition. So they felt more comfortable engaging cultural conversations with clients after just 10 minutes a week for 8 weeks, which is really promising, right? So a lot of this relied on mixed method approaches, which are another thing that I think is really compelling and important here when we talk about provider experiences and how that might impact clients. We can't just be relying on surveys here. I think having a qualitative component really adds to the richness of that data and gets us some better context. So with that, I'll just leave you my contact information, and then I'm happy to chat in any which way that feels relevant to you guys. It's mostly about starting a conversation.
So questions for Stephanie?
I have one. How did you connect with the sites where you were doing the work, I guess?
Yeah, it was a bit of an adventure. So a lot of this was just through informal networking with colleagues around the country. So one thing we did, Melanie, that the data is still being cleaned because it's so much, is we actually worked with IRBs and training sites across the country to link up client outcomes. So the arm I have not tested yet is how this training program might have moved the needle on client outcomes at these different sites. Something like the CTSI would be a huge help here, just as someone who's done this without that structural arm of institutional support. This meant 6 IRBs, a lot of de-identifying data, all that good stuff. And financial incentives, honestly.
Do you know where these sites are located? Do you have any geographical data, if knowing if they're any rural or urban or things like that, or anything like that? Because that's important.
That would be hugely important, Nathaniel, absolutely. I would say with this particular project, we were really interested in trainees. And so we didn't necessarily assess urban and rural experiences. Now, one of the reasons for that is because the trainees themselves are very geographically fluid based on what year they're at in their training program. And so for something like that, I would be much more curious about working with maybe slightly more established folks that have had more time to really embed themselves in the region. So most of these training clinics are going to be recruiting college students, for example.
Any international?
We had trainees who are international students in the sample, and the vignettes and training material that we used did actually include one international student as a clinical stimuli alongside 8 other vignettes. So there's some opportunity there to go in and dig into those things, but it would be very, very descriptive in nature. I wouldn't use anything inferential on that. I more offer that study up as kind of an example of what is possible moving forward. I do think adding urban and rural components, international components is certainly doable, especially with something as scalable as an online intervention where you can develop very specific stimuli for whatever you're interested in. So the open access resources are available through the presentation if you want to see how some of those videos can be crafted and developed alongside more didactic information.
Other questions? Oh, maybe there's one in the chat here.
Yeah, Gina asked if I've worked with nurses. I have actually worked with nurses some through Penn State Hershey. We've done some qualitative work unpacking nurses and physicians' experiences of cultural humility working with pediatric patients, which, as I'm sure Gina knows, opens up a lot of family systems implications as well. And that article will be under review as of this afternoon when I get off this call.
Well, if there are not additional questions, and certainly feel free to pop them in the chat for Stephanie or reach out on the Teams channel if you're interested in collaborating. We will move to our next presentation. Thank you so much, Stephanie, for presenting. I would like to introduce our next presenter, Dr. Melanie Hetzelrigen from Penn State Barron, who is actually a colleague of mine own. Dr. Hetzelrigen, Melanie, please take it away.
Excellent. Thank you for inviting me. I'll admit, there's so much to share with what I've done, so I'm going to do this relatively quickly. So I want to talk a little bit about a project that I've been working on off and on for about 10 years called Purple One. It is a collaborative work project with one of our local domestic violence agencies, as well as a number of people in the field. So Purple One right now is a comprehensive community level primary prevention program. And it came out of a large community grassroots movement started by the executive director of Safe Journey, which is a certified domestic violence agency in Union City, as well as trying to find, I've lost my page now, as well as in partnership with, at that time, the chief of police in Corey, PA. So together they identified through their work together, serving interpersonal violence victims, IPV victims, just some of the areas where there wasn't a good community connection, where police and domestic violence agencies were not connecting, or with medical centers, and it blew up. And so what they did together is they created the Rural Area Domestic Violence Task Force, in which I was very glad to be a part of, both because that's my area of research, but also it's something personally I'm interested in. And so that particular group, which started in 2015, was a multidisciplinary, still is, a group of professionals from the rural Erie County region that include law enforcement, judiciary, education, local businesses, medical and mental health, housing, faith-based communities, social agencies, and government agencies, as well as other community organizations. So they started meeting in 2015 when they recognized this area of need around how those different organizations and agencies work together to support victims of intimate partner violence. I happened to be there going, hey, looks like you have some data one day. I happen to really enjoy statistics on Fridays. Can I help you? And that led to larger conversations with when the partnership with Penn State Barron Core, which is one of our community outreach and research institutes here at Penn State Barron, led to some potential new opportunities besides just better referrals and coordinated community response, because I like writing grants and things. And so we end up partnering with Safe Journey and a number of those other agencies to write a successful Office of Violence Against Women grant in 2017 that was funded. And out of that work was the development, among other things, of this primary prevention program. And the 3 areas of that came out of that are a Purple One training on IPV, which I helped develop and evaluated, a social norms marking campaign, and a safe places for domestic violence victim network. I don't know one thing. So this has led to this general Purple One program. Purple One was developed, the training was developed based on evidence-based practices and bystander intervention, based on evidence that is well known in the literature. And I worked with a number of the members of Safe Journey to develop one specifically for IPV in this region. That's gone through multiple iterations at this point. We did some evaluation. We've trained now probably over 1,000 people, but the first, I think I have a little under 400 people looking at pre-post tests, and it's shown that it led to very successful outcomes in terms of reducing violence myth acceptance, increased knowledge of IPV, increased ability for bystanders to be effective. They acquired new skills. They became more trauma informed. They were more likely to refer. Led to a lot of significant outcomes, and we've done this a few different years, and it's moving out. The second part is a social norms marketing campaign to increase community members' ability to recognize IPV and respond, and that led to this entire recognize, respond, refer that's coming out now. That's throughout our entire county. And the social norms marketing campaign has demonstrated preliminary effectiveness, lots of high levels of media impressions that led to higher levels of referrals. So like 120 physical media impressions, almost 120,000 radio impressions, over 2 million television impressions, and led to a lot of different materials and media being developed. And there's also now this development of the Safe Place for Domestic Violence Victim Network, which started in just Erie County and then moved into sort of Crawford, Venango, a little bit outside. And the research has demonstrated that this has been effective by seeing an increase of up to 200% of referrals. And all of this was only possible because of the relationships and community engaged work that was between Safe Journey, which is domestic violence, medical centers, law enforcement, our work here as evaluators, and the ability to work together as a team. And so identifying this community need that we are able to bring the evaluation, the assessment, the evidence-based practice work that has led to now what's happening next is where it's going national. So this is the website. Again, 10 years in the making now. If you look, they're doing trainings all over, some locally, but some throughout the world. The biggest thing I want to show is the Safe Place Finder, which started just in Erie County, but that's the number of places now throughout the county they're about the world that's been developed, and they're going global. And so the reason why this, I think, is important is because now we're moving forward to expand. We've got an interest throughout the nation, truthfully. So now we submitted a CDC grant. Don't know what's happening with that given all of the things, but the idea is to examine its effectiveness and impact throughout the nation. So we've got 2 sites identified and 2 more we need to find if this is getting funded. And even if not, we're going to do some version of it to see if this works over time in other places. And so those are some of our questions. I basically just wanted to share in my experience, this is one of many of the community engaged projects that I've done, that it really was essential for the people who were doing the work to help shape the questions, to help identify ways to collect the data, to determine how best to present that to people, to give iterations on the different surveys we did or processes we did throughout the entire process, or else it wouldn't have grown and been now a national program the way it has. What we are seeking, again, whether or not this is funded, we either might seek other funding or even find a way to do it through other resources, is as we're trying to expand and show its effectiveness throughout the nation. If you know anybody, if you have connections throughout the country or other people who might be interested in helping identify ways to modify this based on the location. So right now we have 2 places, one in Illinois and one in Texas already identified, but we'd like to get something in the Northeast. We'd like to get something in the Southeast, Northwest, to try to evaluate it. The best thing I have is in terms of just suggestions on what's been really effective is go not as the expert, but as someone to help. And then it has led to just all of these other opportunities that has just grown. So I don't know, that's sort of my presentation. It's kind of haphazard because that's the type of work this is, right? It's not, you keep going with what opens up to you. So thoughts, questions? Any questions?
I actually have one.
Sure.
So, and I'm curious, what are the processes for outcomes tracking that are being used as part of? So I know you had talked about some of those outcomes, but I'm wondering how that's being sort of, the data management set up across these multiple different sites. Yeah.
Yep. So as it's developed, again, this is one of the things that happened out of this when we first were doing some of the work just in Erie County, and then we moved into some of the surrounding local counties. We were able to connect with a company. It used to be called Ohana Link. It is now called Loop Solutions. And it is a tech startup company that the owner has a real big passion for reducing intimate partner violence. And so they have partnered with us and Safe Journey to develop metrics through their online platform, which allow for training purposes, checking things like attendance, completion of trainings, changes in outcome variables, among other things. And they're also working on tracking referrals and other things, all in consultation with both the Rural Domestic Violence Task Force and myself from a research standpoint. And so because of that partnership, which came about almost out of luck because we were doing a training in there, that has allowed us to really develop some tracking measures through the online portfolio, which is helpful because trying to identify and train people on site at these different locations and making sure they're all at the same level was going to be a bit of a challenge, and this was a benefit. We're still working on others as we're expanding, but that's the primary way we're tracking data is through this partnership with Loop Solutions and in their work with us.
Thanks for that. You have is in the chat as well. Excuse me.
Metrics pulling from the website. Can people access training materials online? So I'll answer the second part. The training is done through either virtual or in person. It is not just something you go and do because of it's a lot of interactive nature. So as of right now, purposefully, it is done either by there's 4 identified trainers at Safe Journey, and then they're working a trainer model, and they train a few other people, but they need to be either through virtual online like this or in person where the training happens. And then there's checks. So there's checks, I think, every 6 months to a year for making sure that the training is done to to satisfaction, that it meets the levels. Metrics pulling from their website. So right now, the metrics that are being pulled from the website are things like it's predominantly not so much the social norms, but on the training and on the Safe Place Finder. For Safe Place Finder, it is number of clicks, number of referrals, number of people served. So a lot of those output information. On the training, the initial survey that I did that was pre and post has been integrated into the online sort of connection to the training, the registration, as well as an evaluation of satisfaction and then a 6-month post follow-up, which is then we're determining where those people are who are doing the training and what site they're associated with, and then tracking referrals and phone calls to those sites within the next 6 months to a year afterward.
Do you know what populations you are serving? Is it people who are mostly serving children or with violence, or elderly with or people with disabilities? Because they may have workplace violence because of ableism and things like that, and I just wanted to ask you that question.
Yep. This particular is geared towards intimate partner training. So partners and possibly their children within relationship violence. So not workplace violence, not specifically violence towards children, except for as it is a secondary piece to like domestic violence.
People with disabilities.
Those who have disabilities who are in an intimate partner relationship and experience violence, yes, it is not elder violence. That is not a focus of this particular training. It could be expanded, but the focus of this was particularly on domestic violence.
Okay.
Additional questions? I think we have time for one more.
Thank you. If you have any other questions, I'm in the thing. MDH33 is my email. So.
Thank you, Melanie, for your presentation. So for our final affiliate showcase presentation this morning, I'd like to introduce Dr. Nima Kodakarami, who is from the Penn State Beaver campus. Dr. Kodakarami, please take it away with your presentation.
Hello, everyone. Thank you, Wilson and Nicole, for arranging this event. I really appreciate that. And I just learned a lot from Stephanie and Melanie. It was a wonderful presentation. Thanks. I had no idea about all this stuff. It was a learning session for me. Thanks. So I'm an assistant professor of health policy administration here at Penn State Beaver, and also adjunct faculty at Texas A&M Southwest Rural Health Research Center. I guess with the shortage of the time, I'm just gonna skip a lot of the things that I have provided here, but this work has been, it's in the process with the collaboration with Mark Holmes, director of University of North Carolina Cecil G. Shepp Center for Health Services Research. So I'm open to collaboration, just working over all other, basically the projects that I'm doing, just to give an idea of any collaboration. I'm mostly work with claims data and policy analysis. So, for example, right now we are this project that I'm going to present right now. We are preparing this for health affairs. We are submitting to other research, to health services research on the effects of Medicaid unwinding, and the number of the papers on basically individual level analysis, mostly pediatrics, as well mental health at national level using age group data, and something in that basically area, normally working with again data. So just to give you an idea what what's basically my research normally looks like. Here we are going to basically look at like the effect of rural hospital closure, just the motivation of that, basically the rural hospital closure has been on a rise since only 2010. Over like 100 rural hospitals have been closed, and about 7 more hospitals are at risk of closure. And from the basically the picture that I collected here from the Center for Healthcare Quality and Payment Reform, you can see how Texas is one of the states that are at high risk of observing lots of basically rural closures. So I need to keep track of the time. Okay. So one of the basically one of the motivation that we are using Texas, not only because it's a larger state, but it's one of the states that because of my affiliation with Texas A&M, I have access to quarterly data that are publishing every quarter, and we have it up to 2024. So we can basically follow individual across the time. But at the quarter level, not at month level. Follow individual at the quarter level across the month. So this has been the motivation that we started basically working on this paper. And normally, actually, we know that about 20% of the Americans are living in rural area, and basically closure of these hospitals could have a lot of like the adverse effects on their health, other than basically how much of travel they have to go, how would that basically impact the delay of the care. And but there are not many studies observing what would happen to the nearby hospitals. Basically, we want to see what's the spillover effect of the rural hospital closure on nearby hospitals. So there are only about 4 studies. I'm going to skip all those 4 studies. The first one has been actually done with our colleagues from the Penn State College of Medicine. The other basically coming from the again UNC Shep Center, and one from Texas A&M University. So majority of those are kind of like our colleagues. But this is basically the study that we are doing with Mark on focus on the effect of hospital closure on nearby facilities in Texas. We estimate changes in admission, visits, payer mix, and case mix in neighboring facilities. Some of the basic talks that has not been yet studied in depth. So what separates our study from others is that if you look at like the graphs in the left-hand side of this picture, you can see basically if you assume that orange triangle are basically rural hospitals, and the blue circle is all neighboring hospitals. So the current study shows that if we, let's say this square is an area that you assume you keep it fixed, and you're going to study what would happen to the people within that area, right? So you assume that if this basically orange is disappears, so basically rural hospitals closed, what would be the effect on the other hospitals? So is it going to be increase in their inpatient, outpatient, emergency department visit, or decreases? They don't really look at what is happening prior to closure. So what we are going to look at, we are not basically looking just at average changes, but prior to closure, we want to see what hospitals are receiving majority of the rural patient. Because if you look at like the rural area, you can see a lot of basically patients are bypassing rural hospital just to go to another hospital to get services. And actually, that's one of the reasons that you can see prior to closure, even like the inpatient, outpatient are decreasing. So, and that's one of the incentives that many hospitals are closing inpatient settings and just keeping their outpatient or emergency department. So basically, we want to see kind of like those responses, to see the hospitals that are already receiving a high share of rural hospital after closure, what would be the effect on them. And the adverse effect of that would be on basically higher lengths of stay and so on and so forth. So I guess I don't think I have that enough time to move over everything else, but so I'm gonna skip all of this and just show you by this model. Actually, this is a number of the hospital that you can see in Texas was closed. And one other thing that has been missed in prior studies, they're just keeping that square as a fixed area. So they are looking on average outcome in neighboring hospitals, but they don't observe how many hospitals are nearby within that distance. So here, for example, in this study, as we look at, it's only for outpatient, for the hospital closure and all within 30 miles of the rural hospital closure. So you can see close to only one of the hospital or only 8 hospitals, but when you move to the hospital number 11 that was closed, 103 hospitals are within that 30 miles of that basically closed hospital. So you cannot basically say that within 30 months of the hospital closure, the outcome was universally experienced across all hospitals. So it's still in progress research, so we are still doing some analysis on that. So we don't have that much. We don't have any outcome to share. It's just like some observation that we already have. For example, you can see like the pre-closure, post-closure on the nearby hospital, there has been an increased number of the patients. But if you look at like the size of the hospital pre-closure, the hospital was basically providing 416, but the increase was about 3,420. So if we go with the prior studies approach, we could say, yeah, there has been an increase. However, we cannot basically literally say that because only at most 416 of those patients, these patients are coming from rural. So therefore, the increase in these basically hospitals are not coming from the rural people. There could be some other factors. So that's why we are basically breaking all the research in more journal items to see what is happening. And just to give you another basically idea, disregard this, there should be something here that I have to go and check this again. But these are basically the number of the visits. The blue shows the number of the visit pre-closure. Red shows the number of the patients who already bypassed the hospital to go to another hospital or to other hospitals that could be even further than the rural hospital, but they are they opt to go to another further hospital rather than going to the closer hospital. So you can see like the basically after the closure, at some hospitals, for example, for this Renaissance Hospital trial, like the bypass hospital kind of like the jumps increased significantly. So the trend has a like upwarding after the closure, but for some that bypass hospital has not observed that much of the jump post closure. Again, still some observation. We are still moving forward, so this is not something concrete that I can show any results. Just want to share how my research applies, and I guess I'm going to stop here, so I'm not going more over the time. But thanks for the time and thanks for your attention.
Thank you,
I
Nima.
just have a quick question.
Yes.
I noticed no census data, like compared to the, if it's rural, it's mostly because there's no race ethnicity, there's no Amish or things like that, or populational data. So how does that compare with the
Well, I skipped
data?
that.
Because where it's located, I'm just a bit concerned that because that if a population is rural and for some reason there's a lot of Hispanics, is that more likely to be closed than a rural hospital that is mostly white, non-Hispanics?
So thanks for the question. I appreciate that. So that's why I skipped that. Well, basically this, as you can see in the table in this, basically it shows like the overall the demographic of the patient in rural hospital, and because we are basically studying Texas, what we see is the majority of the rural population are kind of like not Hispanic white. But
I don't see any Indian, because I
so
know in
it's-
rural company there might be a lot of Native Americans and they're spread out, or
Yeah,
other races.
Yeah, they're basically because the proportion was much smaller in the close, because I'm here, but you see it's a basically closed hospital. so it was not that high. So for example, here you can see about 1990s, about 4% of the population were some other race ethnicity population. But again, it's just like at the beginning of the research, definitely it's going to be included. It's not something that we can oversee that. It's of course, it's one part that describe the rural population, but this is a really good question. Thanks.
And do people, when close it, base it on the census of the population surrounding it? Because the U.S. Census gives a decennial census, and if the population is mostly minorities, that could be justification for keeping the yes. I don't know how they decide that, or if there's a lot of hospitals in the surrounding area, like in Harrisburg, they have because they have UPMC and Hershey, for example, because that's competition. So is it areas where there's no competition, or how much does that come into effect?
So, well, that's one of the basically things that are really concerned about the rural hospital closure. So, for example, one of the hospitals that has been closed, there is no hospital within the 30 miles of that. And I guess at some points, maybe in the rural hospital that are closed within metro area, so there are about 103 hospitals. In another one, there is no hospital within the 30 miles of that. And from my total understanding so far is that basically their decision on closure is just based on like the profitability of the hospital and the changes in the payer mix and all the, and the population of the region. So again,
How about what services provided? Because if there's because like say I'm using abortion for example, in some states they outlawed abortion. How many of them? Is there any information on what services the hospital actually do over time? And that might be important if somebody has a needs a colonoscopy, for example, are they able to go to that hospital, or do they have to go long distance? Because that's important to know these services and how it changed over time. That might be another fact.
Yes, thanks for asking that. So far we know that basically, again, I skipped a lot of those. I guess many of like the people who are affected are the mothers and children, and there are so many preterm births, cancer patients, patients with sepsis, stroke, AMI, asthma, COPD are the people who are mostly affected. So there were a new basically policy that led hospitals to keep their outpatient services but close inpatient. So I guess it's something that's still concerning. That has been the motivation that we are doing that. But definitely those are the items that we're going to dive into, that specifically focusing on different types of the diagnosis condition, not only the payer mix. And again, I said that we're going to also check out the case mix of the hospital. But thanks for asking all those interesting questions.
Hey, Naeem, I have a quick question.
Yes.
In one of your first slides, you identified hospitals that were at risk for closure. How do you and your team identify hospitals at risk for closure? Is there a particular metric? Do they report that?
So this is reported by Center for Healthcare Quality and Payment Reform, and I guess they go before I haven't honestly dived into basically. I haven't dived into that to see on what basis they're expecting this hospital to close, but I assume based on, again, before the closure, what we see that majority of like the inpatient, outpatient, or ED visits in this hospital are dropping. So the current research shows that before closure, they are decreasing in some area, and then that basically lead to closure. So it's basically, I guess, one factor would be based on the changes in the number of the patients that are providing, and also based on the profitability of the hospital. So I guess maybe they go through like the doing some based on what has already been closed, or I don't know on what basis exactly they are saying this hospital, 20 hospitals for example in Texas are at immediate risk of closure, and over 700 are closure risk, but I know that mostly are based on like the financial profitability that they are doing that, and another is that some of the rural hospital are basically, especially critical access hospital, has been acquired by private equity. For example, there was one that has been closed in Philadelphia, I guess, in 2019, that was providing a lot of services to vulnerable population, but it was just because it was bought by private equity and it was just the profit maximizer, so it was not profitable. They closed the that basically critical access hospital. So I guess it's, yeah, my assumptions are basically on profitability. But thanks for the question.
Of course, thank you. And I wonder, Nicole, if it wouldn't be a good next step to connect Nima possibly with George Garrow, who we're working with through Primary Health, the Primary Health Network. He was interested in the closure of regional and rural hospitals, had presented a bit on it at our last CTSI meeting here in the state of Pennsylvania. And there were some both UPMC and Primary Health Networks hospitals in Western Pennsylvania that have been closing. So I wonder if we can translate that research here to the Rural Health Network of hospitals here as part of Pennsylvania.
Perfect. Thank you. I appreciate that.
Yeah, you bet.
Absolutely. That's a great idea, Wilson.
Other questions for Nima? We have a few minutes left remaining.
I just wanted to jump in here too. If there are no other questions for Nima, a few quick things. One, I have to sincerely apologize to Stephanie. I only gave her 5 minutes to present when she should have had 10. So I'm very sorry for that. That was my mistake. And I wanted to invite her to come back on if she's interested, if she had any additional information to share, Stephanie. We'll also share everybody's information and PowerPoints out after, but that's the first thing. And the second thing, I just wanted to let everybody know in webinars moving forward, there will be a chat function. That was another mistake of mine. This is the first webinar that I've hosted via Zoom. I've only ever done standard Zoom meetings. And so there's no chat function here for all of us to discuss while people are presenting. So again, I apologize for that.
Hey again, Nicole, no worries. It's Monday and you should have seen me try to put someone in a breakout room last week. After 2 years of teaching online during COVID, I could not do it. So that also probably serves as a thing that I would not be, I'm going to present all this stuff on tech and I can't do a breakout room. So no worries at all. I'll just kind of pop back up this. It seems like a lot of folks are interested in hospital-based things, which of course makes sense. So one of the reasons why projects like this are potentially helpful is because it can be very flexible in its implementation. So this is the deliberate practice one I mentioned. And all that means is that you allow the provider an opportunity to practice the skill repeatedly, and then you give them very detailed, personalized feedback. So that process can be difficult to make scalable, but train the trainer models become really helpful here. And what we found too is that even in these quick 5 to 10 minute weekly interventions, it took me as the lead supervisor maybe an hour a week to effectively give everyone their feedback. So it is doable. And again, that was with psychotherapy trainees. So the 6 IRBs and the nationwide data collection was specific to university training clinics. But something else we did recently in hospital settings was we talked with a lot of physicians and nurses about their experiences with cultural humility. The idea there was to get a sense of how you would even do quick assessments, quick meaningful assessments of someone's cultural humility or comfort. And we have found through some of these studies, which are listed here, is that there are ways to get at that information pretty quickly. So there's a lot of really interesting opportunity there for interprofessional development and feedback systems that could be done without taking up, again, too much of providers' times. Because one of the big barriers we found to their work is they often wanted to be able to practice cultural humility and comfort, but that, someone actually said you can't bill for relationship building. And I thought, gosh, that's so sad, but it's also the reality of things, right? Especially as Nima was saying, in the context of hospital closure. So that's just like a bit more context of how these things can kind of transcend different intervention or healthcare settings. And thanks, Nicole, I appreciate it. Pop that back off.
Thanks for your flexibility, Stephanie. Just to round out the last minute or two of our presentation, I'd like to thank our presenters for their time and flexibility in this format. To those of you who are interested in these particular topics and who might be interested in collaborating, I encourage you to pop onto our team's collaboration chat, where some information will be presented on each of these presentations today. Feel free to share and distribute our webinar video once it's posted as well with other colleagues who might be interested in these spaces. That's the purpose of our program, is to disseminate this throughout the internal affiliates network at Penn State so that our research can be conducted at a more robust and higher quality that reaches Pennsylvania residents, part of the research platform of Penn State CTSI. If you have additional questions as well about Penn State's CTSI affiliates program, you can reach out to myself as the faculty program lead or Nicole as our staff program lead. Without belaboring anything furthermore, I wish everybody a wonderful week as we're rounding out the semester. Take care and stay tuned for details about our next quarterly seminar.
Thank you.
Thanks,
Bye,
everyone.
everyone. Thank you.